afternoon, everyone, and welcome to today's edition of Black Health Trust. We are so happy that you have chosen to spend some time with us. We're looking forward to spending some time with you. I am, and I never say it, and I forget to say it, I'm Barbara Neighbor-Stevens, one of the co-moderators of Black Health Trust, joined today by my co-moderator, Dr. Ivan Walks. I saw something that made me think about what we try to do here at Black Health Trust. We try to provide as much vetted information as we can. And I saw a CBS poll that said the question was, what is the worst enemy or the biggest problem for facing the United States? And the top answer was other Americans. And I said to myself, that's not a new phenomenon, because if you think about it, the children of Israel were their own worst enemy during the time of Moses. The reason they had to wander around for 40 years was because they wouldn't do what they needed to do to take care of themselves. So apparently, and I'll defer to our psychiatrist, that is the nature of humans. We work against ourselves. And we're continuing to work against ourselves. Hence the topic of today's program, which is It Ain't Over. And we are so happy to bring back one of our former guests, Dr. Dow Hewlett, who is the medical director of the Division of Disease Control and chief of tuberculosis services in Westchester Department of Health. That would be in Valhalla, New York. And without further ado, I'm going to turn it over to Dr. Walks.
Good afternoon, everyone. And good afternoon, Dr. Hewlett. It's good to have you back with us.
Thanks for having me.
Absolutely. Dr. Neighbor-Stevens, you're right. We tend to work against our purposes, and it seems to be what we do. I think one of the challenges is that we don't always get good information from anywhere, it seems, consistently. And so it's reasonable that folks are continuing to look for what you described earlier as vetted information. And that's what we do here at Black Health Trust. And we oftentimes are blessed to have good messengers like Dr. Hewlett join us to be able to bring that kind of information, that vetted, trusted information. So without further ado, I'll turn it back to you to introduce Dr. Hewlett again, and let's get started.
Well, I will very much abbreviate his bio. Dr. Hewlett received his MD from the University of Wisconsin and did his residency at the esteemed Harlem Hospital of New York, and went on and completed his infectious disease fellowship at Montefiore. Dr. Hewlett has served for several years in the health department of New York and is well established as a public health official. And, you know, New York seems to be the hot spot of stuff. So who better to chat with us today than someone dealing with the state of New York? So without further ado, let me turn it over to Dr. Hewlett.
Okay, thank you so much. And it's always an honor and a pleasure to be able to be in this kind of a setting where we can talk about how we can do things to sort of help ourselves. And I had the honor actually yesterday of being able to speak with a group of people at the church which my wife and I attend. And one of the things which we were talking about was there's certain things that we cannot change. I think that's like one of the scriptures actually, and we have to have, you know, the grace to understand those things that we can't change. And one of those things we can't change is pandemics and epidemics, such as COVID and influenza. We know that that's with us and we can't change that. But what we have to do is we have to have the courage to change the things that we can change. And one of the things that we can change is we can protect ourselves and we can protect our patients. We've been given tools like vaccines that we can use to protect ourselves and to protect our families and those around us. And we also have to think about things that we can do that will put us into a better position when the pandemics arise. And there's been less attention paid to these things. And I think all of the people on this call are familiar with those things, which include diabetes and underlying diseases like hypertension and heart disease and weight control. All of these are things that we have to really focus on so that we can prepare ourselves and our patients for the next pandemics, which we know are going to occur. So let me see if I can pull up the slides here. I can share my screen, and let's see if I can pull this up here and share this. Okay, can everyone see the slides?
We're good.
Yeah, we can see
Okay,
them.
great. Okay. Let's see if I can. Okay, so I'll start with this update here. I'm going to try to, this is a very brief update, and then we can have a discussion afterwards. We're going to talk a little bit about some of the updates in terms of the guidance that we have and some of the problems that we are facing also. So as you probably know, the CDC expanded and updated the COVID vaccine guidance, and it now includes children down to the age of 5 through 11. So as far as the bivalent booster is concerned, it's indicated for children down to the age of 5 years. And so that includes everyone in the United States who is 5 years of age and older is now eligible for the bivalent booster, provided that they have already completed the primary series. Now, the CDC director, Dr. Walensky, signed a decision memo expanding this just a few days ago, and this follows the FDA authorization of updated COVID-19 vaccines from both the Pfizer-BioNTech as well as for the Moderna. Now, one of the things which Dr. Nesbitt Stevens was talking about originally that really triggered the need for this discussion had to do with the fact that the BA4 and BA5 lineages of the Omicron variant are essentially our main focus of concern at this time. Now, according to the FDA, BA4 and BA5 Omicron variants are currently causing most cases of COVID-19 here in the United States. And importantly, BA5 is most contagious, and it accounts for now probably around 90% of all cases nationally. Now, with that in mind, the problem is that less than 3.6% of eligible persons in the US have received the bivalent booster as of September the 30th of this year. So that was just a week and a half or 2 weeks ago. And one of the things that we know, and I think that it's fair to say, that if this is 3.6 of eligible persons across the US of all races and ethnicity, it's very likely that that number is probably less than half when we talk about our African American communities. Only 40% of US adults received the third shot of the vaccine, which was recommended in 2021 for everyone. And of course, we know that there was a supplemental schedule that was developed for people who were immunocompromised. Now, contrast that to what we see in the United Kingdom, where 70% of eligible persons there received the third dose of the vaccine. Now, one of the things which we have to keep in mind, and let's see if I can clear this here. One of the things which we have to keep in mind as we talk to our patients and we talk to people in our families, because all of us, I think, have people in our families who've been very recalcitrant when it comes to the vaccine, is that not only are we trying to prevent the initial infection and the consequences of that initial infection, but we're also trying to prevent the complications of long haul COVID or long COVID. And we now know that there's an overrepresentation of African American patients, and at the same time that there's an overrepresentation of our African American patients, we have limited opportunities for our patients. And one of the things that we all realize is that when you set up these centers of excellence that are designed to treat patients as well as to have a dual role in terms of research, that these opportunities are rapidly gobbled up by people who have really inside tracks and people who are very savvy in terms of their healthcare needs, and our patients are often left out. And that actually occurred in areas like Washington, D.C., where you may recall when the vaccine was first made available, even in the areas that were predominantly African-American areas in places like Washington, D.C., you had all of these people coming in from the suburban areas to get the vaccine, while our patients were sort of sitting there on their stoops trying to figure out what are all these people doing in our neighborhood. And so we have to think about this. And as we look at this, the Black community was hit hardest by the initial COVID wave, and we're now struggling with long COVID. A recent study showed that roughly 700,000 people in the U.S. have long COVID, defined as symptoms lasting longer than 3 weeks. And much like the initial outbreak of coronavirus, long COVID has highlighted longstanding health inequities in the U.S., particularly in our communities of color. And while there isn't clear data regarding the racial and ethnic breakdown of long COVID just yet, Black or African American people are 1.7 times as likely to die from COVID as white people, and experts are anticipating increased disparities in diagnosis and access to treatment. And we know that this has already occurred. Now, as we shift gears, and we were talking about this last night, influenza is another very important thing that we have to consider. And in the health department, and I know that this was something that occurred over a period of time, before we really knew what we were doing with SARS-CoV-2, at the very beginning, when testing kits were very limited in supply, one of the things that happened was people were tested initially for all of the other respiratory viruses. And if the test came out positive for one of those respiratory viruses like influenza A, they said, okay, we're not going to test that person for SARS-CoV-2 because they've got influenza. And if you think about it, that actually is not logical. One of our old professors that taught us about tuberculosis said that just because you diagnose strep pneumoniae in a person with pneumonia who has a cavity, that doesn't mean that they don't also have tuberculosis. And the same is true with SARS-CoV-2. You can have influenza and COVID at the same time. And one of the things that has been noticed is that you may have an increase in the severity of disease if you have co-infection, but it's also important to know that if a person is co-infected, that they need to be treated for both of the conditions. And in this small study that was published last year, which contained about 48 patients, these authors highlighted the importance of screening for co-infecting viruses in COVID-19 patients that could be the leading cause of disease severity and death. And given the high prevalence of influenza co-infection in this author's study, increased coverage of flu vaccination is encouraged to mitigate the transmission of influenza virus during the ongoing COVID-19 pandemic and to reduce the risk of severe outcome and mortality. And one of the things that we have emphasized during this pandemic, and we were actually with the state commissioner on Friday, is that we should encourage our patients to receive both the bivalent vaccine if they're eligible for that in one arm, and the influenza vaccine in the other arm. You can give both of these vaccines at the same time. So if the patient is in front of you, take that opportunity to give them both of the shots. And this is something I think that we cannot overemphasize in our community. And you probably recall some of the data from the pandemic of 2009 with H1N1. There were new studies that identified racial and ethnic disparities in severe flu outcomes. And in August of August 21st of 2021, CDC identified racial and ethnic disparities in severe flu-related outcomes across 10 flu seasons dating back to 2009 through 2018 and 19. So this is not something that was just 1 year. There happened to be a higher rate of morbidity and mortality in our African American community. This is something that has occurred year after year after year. So in this study was the largest of its kind to examine and analyze racial and ethnic differences in 3 categories of severe flu outcomes, which included rates of flu-associated hospitalization, ICU admission, and in-hospital death. Overall, adjusting for age, Black persons had the highest flu-associated hospitalization rates across all 10 seasons, with similar trends for the ICU admission rates. And I apologize for the formatting on this slide, but the other thing which we have been talking about over the last few weeks, and I think that this is relevant for many of us, those of us who have children and our children who are daughters who are pregnant, or nieces, nephews, and others, it's important for us to encourage them to get the flu shots as well as to have the COVID bivalent vaccines if they are eligible. And influenza infection during pregnancy is a very dangerous situation. The 2009-2010 pandemic provided us with an opportunity to examine pregnancy as a risk factor of influenza severity. And there were increased H1N1 associated hospitalizations, intensive care unit admissions, complications, and mortality due to during pregnancy. This was documented worldwide. And pregnancy was identified globally as one of the strongest risk factors for influenza-associated ICU admissions. And pregnant women made up a disproportionate number of the individuals who were hospitalized and admitted to the ICU, and also people who died in proportion to their representation in the population at large. And so it certainly behooves us to encourage all of those in our community, our young women who are pregnant or who are contemplating pregnancy, that they should actually have the flu shots, and they should understand that the flu shots are safe to be administered during pregnancy. So the take-home point, I think, for all of this is that we have to encourage everyone to stay up to date with the COVID-19 vaccines and influenza vaccines, including the boosters. What do our patients need to know? They need to know that the updated bivalent boosters became available for persons who were age 12 and older over Labor Day weekend, and just last week for individuals all the way down to ages of 5 years. And the CDC recommends everyone stay up to date with the COVID vaccines according to their age groups. And of course, in our health department, we actually started giving the vaccines to children down to the age of 6 months. Getting the COVID vaccine after you recover from COVID-19 infection provides added protection against COVID-19. And so I'm sure all of us have heard the argument from our patients and from our family members that since they had COVID-19, they don't need to get vaccinated. And what we try to tell people is that they can actually have added protection and added benefit if they actually will receive the vaccine. And if they've recently had COVID, they can consider delaying the next vaccine dose, primary dose or booster, by about 3 months from the time that their symptoms started. People who are moderately or severely immunocompromised, we're particularly concerned about those members of our community. And there are, of course, different recommendations for those individuals. I think that most people are probably familiar with those, but they actually have additional doses of the vaccine that are recommended during both the primary series as well as during the for the boosters. And one of the things that we should all keep in mind, and I know that I've only had to be involved with this a couple of times, is that if you have a patient who is being treated with immunosuppressives for inflammatory disorders. I know we have a person in our health department who's being treated by a rheumatologist, and we coordinated with the rheumatologist in terms of the timing, where the rheumatologist was able to alter the dosing schedule for the anti-inflammatory and then allow the person to gain maximum benefit from the vaccine. That's something that it's important to do, to try to collaborate with the other caretakers if you have patients who are being treated with immunosuppressives, either anti-inflammatory treatments or treatments for cancer chemotherapy. And the COVID vaccine and booster recommendations may be updated, as you know, from time to time. So as we know, an ounce of prevention is worth a pound of cure. The vaccines are available, and we now, of course, have the Pfizer-BioNTech and the Moderna. It's also noted that we have the Novavax, and the Novavax is a protein subunit platform vaccine. And for those individuals who had issues, there may have been religious issues or other types of issues in terms of using or receiving mRNA vaccines. The Novavax vaccine is an option for those individuals. The Johnson & Johnson or Janssen, we have somewhat curtailed the use due to some of the problems that were encountered with that vaccine, but it is still an option for some patients. So at this point, I think I will close, and we can try to start to address any questions that people might have. But I know this was sort of a short presentation, but I did want to try to get some of the major points out there.
So I would like to thank Dr. Hewlett for accepting a late invitation to come on today. But the reason this was even an issue to bring forward was because on Thursday, the CDC issued a warning about severity of influenza outbreak this winter season. And I thought it was very important that we bring that to Black Health Trust, because although we have spent a lot of time talking about COVID and we have talked about influenza, I don't think the seriousness of what this winter seems to be harboring for us has been appreciated. There have been multiple reports, including from CDC, of recognition of a surge in Europe, with the anticipation that it will be a similar experience in the United States. But Dr. Hewlett, I was wondering if you could speak a moment about why influenza might be more severe, more prevalent this year than in years past.
Sure. I think that one of the things that's been discussed is that during the last 2 years, since we have been in the pandemic, people were wearing masks in a lot of settings, in most settings indoors. Most people were still wearing masks. And that actually, of course, it's believed that limited the spread of influenza virus as well as limited the spread of SARS-CoV-2. Now, we don't know all of the facts around that, but that actually was felt to be one of the reasons. The other thing, of course, is that every winter, at least in the colder parts of the country, we spend a lot more time indoors. You have the holidays occurring. The other thing, which is probably contributing to this, which is more of I guess a societal type thing, more so than anything else, is that people have been they've been prevented from being with their loved ones and their families for a long, long time. And one of the things that we're fearful about is that everyone is going to drop their guard, and they're going to essentially gather with family and with friends, and they're going to be very complacent, and they're going to say, you know what, everything is over, it's fine. We need to wear masks. We don't need to do any of those things. And so that might be another contributory factor. And I know that this wasn't part of your question, but in terms of for COVID, we also are worried that persons who are in our families and in our friends who are immunocompromised, that this is more likely to have a very detrimental effect on them. That they're like the canaries in the coal mine, where they'll be the first ones to actually have problems. So, but that's what I've heard about it so far. I see there was a hand up, Dr. Sherrod.
Yeah, thank you, Dr. Hewlett, for the presentation. My question is concerning Novavax, the new vaccine that's been released. Was wondering if you could just talk a little bit about how you are planning to utilize that in this scenario. What are your recommendations toward its usage? You know, we had a talk by Dr. Hildreth from Meharry Medical College, who's a virologist and also an immunologist, who actually had alluded to the fact that he would probably use the Novavax as his next booster. So I wonder if you have any information on how you think it's going to be, how it's going to fall out. I mean, how can it be utilized, under what circumstances, and what are your recommendations for that?
Yes, thank you, Dr. Sherrod. That's an important question. In our health department, we felt that there was a need to have it on our formulary. And the first place where we were using it was in our individuals who had refused to take the mRNA vaccines. And we more or less approached them and said, you know, we now have something else to offer to you. And some people were willing to accept it. I don't have a lot of data in terms of how it would be useful as far as a booster, but I think the rationale is that since it actually has a different kind of a makeup, and I think the other thing too is that the vaccine was when it was actually going through the clinical trials, it was actually in the trials during the Omicron, during the later surges, I think with Delta and maybe at the beginning of Omicron. And I think for that reason, it's felt that it may actually be protective, you know, against some of those strains as well. Again, I don't have all of the data on that to be able to say for sure, but I think it does offer another option. And since it is a different kind of a platform, you may actually get a different kind of an immunogenic response, but I really don't have enough factual information to share with you. But in our own health department, we did order doses of it, and we are using it primarily for those people who refused the other vaccines.
Dr. Walks, I cut you off before. I apologize.
No, that's fine, Dr. Neighbor-Stephens. Dr. Hewlett, there was a question. First of all, thank you for the clarity of your presentation. One of the questions in the chat was, you mentioned a couple of times differences between the United States and the United Kingdom in terms of how the percentage of folks who were taking the vaccine, and then the bottom part of your slide, when you were talking about pregnancy and influenza, there was also some reference to a difference in the UK. So could you hit a little bit more on what you think that difference in willingness to accept the vaccine is about, and then what is the difference with respect to the pregnancy risk?
As far as the differences between the UK and the US, it's speculative on my part, and the speculation would be that there is likely to be a lot less in terms of political divisiveness in that population. And as you know, vaccination, particularly SARS-CoV-2 vaccination, has been politicized, and people have essentially gone on the side of being against the vaccine who are aligned with some of the political leadership, or at least past political leadership. And I think that was a big factor. We saw that we're still seeing this today among certain factions or segments in our population. And I'll give you one. I know this is again beyond what you were asking, Dr. Walks, but we're doing a study we have a grant from HHS, and we were looking at vaccine uptake. And part of the study is being run in the Department of Correction in Westchester County. And we were looking at both the staff members, who are mostly our officers, law enforcement officers, as well as the resident inmates. And the resident inmates are predominantly people of color. I would say a disproportionate number, as you see all over the country. And many of those who are the law enforcement people are not people of color. We found that it's a very small percentage of the officers were actually accepting the vaccination. And we actually used that as a way to, I guess you would say, encourage the resident inmates to be vaccinated, because we said, look, you have all these people who are guarding you every day and they haven't been vaccinated. So you need to protect yourself against a lot of these guys who are, they don't care about your health. They don't care about their own health either. So you better get yourself vaccinated. So I think politically, of course, they were more aligned with the previous administration. So I think it's the political atmosphere that we have here that has caused that. As far as pregnancy is concerned, the thing I think, and you probably know this very well, probably better than I do, with the pregnancy part of it, there are two portions of it which place the person at a higher risk. One is, of course, the physiologic part of it, the fact that as the pregnancy advances, the woman's lung capacity actually decreases as she gets closer and closer to delivery. And that, of course, is one of the factors. The other, of course, is the immunosuppression that we know goes along with pregnancy, and that actually is kind of like a double whammy. This is something that has been pointed out for many years as far as influenza. So I think that goes across all races and ethnic groups. But I think the problem that we face in particular as African Americans is that we know at baseline, our young women are at a higher risk for pregnancy complications and death during pregnancy than the population at large. And that disparity stands even for our young women who are in the insured and affluent category. And then you have all of the biases that go along with that. So
Dr. Hewlett, okay, Dr. Neighbor-Stevens, let me just get one more in, because I want to take advantage of the fact that Dr. Hewlett is a public health official. And as a former public health official myself, I always found that it was great that we knew all this wonderful science. And it was great that we had all these smart people that we were working with. But our real challenge as public health people was, how do we get the information to the community? And then the difference with public health, I always thought, was that we were always trying to get people to do stuff. We wanted people to show up and do something, show up and get immunized, show up and do something to protect their health. And so the translating of science to the community was always that challenge. How do you in Westchester County, what strategies, what things have you found that work to translate from all the great science that you have to get the community to show up and behave in a way that's to their benefit?
Well, one of the things, that's an excellent point, and that's really the big challenge. The grant that I was referring to was actually a grant that came out of Health and Human Services, and it's a health literacy grant. It is focused on COVID-19. However, it's designed to improve health literacy across all of the areas of health. It's a train the trainer model. So what this grant actually has done is that we have been, I guess, tasked with identifying community-based organizations. So, for example, a neighborhood health center that is located in an area that is serving, let's say, an underserved community like African Americans. A good example in Mount Vernon, New York. I don't know if you're familiar with New York, but Mount Vernon is predominantly an African American community. So they are actually serving as a community-based organization. They then are recruiting people who are, in many cases, members of their staff to become trusted messengers. And you don't have to be a health care expert to be a trusted messenger. So they are being trained then with basic information about health, and they are being asked to host sessions with groups of people, 20, 25, 30 people. It might be someone who has an auto shop. It might be someone who is a barber or a beautician, and they're trusted by the people that they interact with, and the expectation is that they will pass on basic information so that people are educated. And at first, of course, it was focused on trying to get people vaccinated, but it is extended beyond that to try to get people involved with just trying to improve their basic health, in terms of weight control, smoking cessation, management of their diabetes, all of these things. That's one of the things I think. I don't know how this is going to pan out. We're in the second year of the grant right now, and hopefully some of the publications are going to come out, but there has been some positive results came out of one of our colleagues in Philadelphia was doing this with the barbers and the beauticians in Philadelphia, and they actually found that they were able to recruit people and get more people vaccinated by using that mechanism, even having sessions at the beauty salons, that sort of thing. So I guess that's one of the ways in which we've tried to do it. The other is we have tried to hold town halls. And so we have encouraged people who have groups, whether it's through various organizations, to pull the groups together. And one of the beauties of the Zoom format or platform is that it allows us to have these meetings without actually being there in person, but we haven't shied away from in-person meetings either. But that's the way that we've tried to do it. But it's been an uphill battle.
Thank you.
So I want to pick up on something that you had on your last slide, which was call to action. And would you take a moment to discuss with our audience, what should they do if they think they have the flu? And what options are there available to them in terms of treatment?
Well, if they think they have the flu, they should certainly try to prevent being in contact with other people in terms of to decrease the likelihood they're going to spread it to their families and friends, and they should stay at home. Now, if their symptoms are in fact rather serious, they should contact their physician. They should have a test done to see if they actually have the flu, because if they do have influenza A or influenza B, they can benefit from the antiviral treatment. Oseltamivir is one of the things they can use that can be prescribed for them. If they have flu symptoms, it may be something else. And we want to make sure that they don't actually have COVID as one of the other things. Those are some of the things I think that they certainly can do. I think the things that we should be encouraging right now is that people should get the flu shots so that they don't get into those difficulties. And I think we still have a head start. I mean, October is really a key month as far as getting people in for their flu shots, but it's not too late when we get into November and even in December. But we know that once the flu does come to a given community, it's going to probably stay there for about 6 weeks. But even after it comes into the community, you still can get the shot, but it will just take about 2 weeks before you really have you have protection.
Dr. Walks?
So, Dr. Hewlett, there's a comment actually in the chat, and I'd like you to take a stab at it, and then I'd like to address it as a former public health official myself. And I don't know if you had a chance to read it, but if I can summarize it, and please correct me if I don't summarize it properly. The concern is that without more African-American or community-based folks involved in the creation of science and strategies and what have you, those aren't really targeted to our community. And I know when Dr. Hildreth was on, he talked about the African-Americans in particular that were involved in the vaccine development for COVID-19. And though it's impossible to argue against the fact that there is bias within the, and has been bias within the healthcare field that has impacted African-American communities, we certainly have had more people involved, and more recently in particular, have prominently had people involved. So I just wanted to have you comment on that, because it's an issue that I hear in our community. Well, that's not our stuff, that's their stuff, and they're trying to get us to do it. So can you comment on how maybe that's impacted you and the work that you've done, and how you've addressed it?
It has impacted us, Dr. Walks, and it's a tough problem. One of the things that's been talked about, and we have a group of African Americans in infectious diseases who the group has actually started to grow over the last few years. But we have been trying to figure out ways to approach this. We actually wrote a position statement to the Congressional Black Caucus back in April of 2020. And one of the things that we pointed out was that we should have incentives for our younger individuals who are getting into the field, things like loan forgiveness. There should be things like, if we think of pandemics as wars, essentially, then people should receive combat pay because they were fighting the virus. They weren't fighting bullets, but they were fighting the virus. And so they should receive some sort of reimbursement. Maybe their medical school or their nursing school or their pharmacy school fees should be paid. That's one of the things that might actually then allow people to come into areas like infectious diseases and public health. A lot of our students are now saying that they're not going to enter some of the fields because they're less lucrative than some of the fields that are more procedure oriented. And so we end up with a disproportionate number of people in other areas. And so, of course, if you don't have people in the specialty, then you're not going to be able to generate principal investigators. One of the things we're trying to do within our small network in infectious diseases is we're trying to develop partnerships, if you will, and I say that in a very cautious way. I should say collaborative types of arrangements with the pharmaceutical industry, so that they will start to help us to develop investigators of color who will be able then to recruit patients from the various areas that are underserved, so that we have a greater representation of our patients, so that it's not really patients that were from other communities and not our patients, but that we also have a higher representation. And I would have to say that if we look at what Moderna did, I think they did a much better job in terms of having, I think they had up to maybe 15% African American representation in some of their trials, and some of the other companies are trying to do similar things. But it's a formidable task, but I think we are really working on this. But I think getting investigators trained and having a commitment on the part of the industry is going to be very important. And unfortunately, the industry is business driven. And so they are going to take the low-hanging fruit. And if they go to Dr. A, who happens to be a well-established majority investigator, and they know that that person will enroll 20 patients very quickly, then they're going to keep going to Dr. A. But then you have another person who is in an underserved community, and they aren't given the opportunity. So we have to figure out how we can sort of equal things, and so that that doctor who's in the underserved community will also be given an equal opportunity to be engaged as an investigator. But
thank you, Dr. Hill. Tony Wofford has raised the issue that I raised, and I didn't realize that Tony Wofford wanted to speak. So I would love to have you join us and either elaborate on your concern or raise a different one, please.
First, thank you guys. I've been checking you guys out for a while. I appreciate what you're doing. I think one of the things, what you said, Dr. Dow, we don't have to apologize for collaborating with pharmaceutical companies, because I think everybody, I take medicine, I take high blood pressure medicine every day. I think they're obligated to actually work with us and support us. And we're obligated to actually have them actually step up and do the right thing. It's criminal for me in my community when they're doing research trials and studies and the PI doesn't look like me. That makes no sense. and then you have an African-American PI who's an assistant or something like that. That's ridiculous. And they have the resources for physicians, especially guys that are new, actually, that want to become investigators or researchers. They have the researchers, they have the resources to actually help support staff and all those other things. And I think I think there's no way in the world we should ever play low because they have another doctor who actually has who's actually been in the game long enough, and he can write more scripts, that all of a sudden he gets in front of the line. It don't work like that. And I think we need to collaborate more so with community. And I think what happens is a lot of times, I think we don't do as good a job as we could do in terms of the medical profession. I'm talking about Black people, physicians working with people Black in the community. And we have to have demands on people, because I work in HIV, been working with Dr. Gail Wyatt out here. I work with Wilbur Jordan, Deborah Wafer, and the list goes on and on. I'm a community cat. And the reality of it is, you can't just work with me in the community. If you can't deliver, then I'm not working with you. I'm not rolling up to a church just because you got 1,500,000 members, because they don't really produce. Most churches, as you know, in this country, especially Black ones, have average 50 to 100 members. Those are the ones that are going to do the heavy lifting. We have to actually, we cannot continue to suffer historical amnesia as Black people, how to work with Black people. My cousin's barbershop is here in LA. And whenever the LA Times or C-SPAN or list goes on or want to know what's going on, they go to that barbershop. I read the LA Times every day, but I also read the Los Angeles Sentinel. I want to read the Times, see what people talk about, but I would need to read the Sentinel to find out the truth. And I think what we need to, in fact, do is come together, and we have to, and this is the last thing, I'll let go because I could go on forever. We have to come from a Black perspective. I'm for collaborating with Brown and all that. But the reality is, we're a special people that have a unique and special problem. Some social conditions have caused a hell of a problem in our community. And we need specific programs to address specific issues that affect us as Black people. And we cannot be scared to say Black people. Because if you're scared to say Black, just say the data. You know what I mean? Let's look at the data. That speaks for it. If you're scared to say Black, either call me and I'll say Black for you. But we have to do that. And we can't keep doing what we keep doing, because we always won't get what we always got. I'll let it go, because I could go on just forever, y'all. But I appreciate it.
So Mr. Wofford, first of all,
Tony,
thank you for making your statement and speaking your piece. I think we all appreciate it, because we spend a lot of time talking about keeping it real. And I think that when people actually do that, sometimes we kind of back away a little bit. And here at Black Health Trust, we don't want to do that. I think what Dr. Hewlett talked about with the specific efforts and collaborations and partnerships that he spoke about. I actually trained in LA, and I know Dr. Gail Wyatt very well. I trained at UCLA when she was there, and I grew up in LA. So I know that I was heartbroken by what I read in the news the last couple of weeks about what had been going on with the city council, because we do need to collaborate. We are challenged a lot by the people we try to collaborate with. Let me say this. The work that Dr. Hewlett talked about in trying to collaborate, when you begin looking at the pharmaceutical companies and how they connect with many in our communities, a lot of us, and I say us, Black practitioners, doctors, we don't have a lot of the things that fit well with them, like electronic medical records and things like that. It sometimes is harder for them to work with us, which means that we have to do what you said. We have to insist that they work with us. We have to hold their feet to the fire, because it's a little bit harder for them sometimes to work with us. We have organizations. I worked with Robert Wood Johnson and the Community Health Councils Project in LA, working in the community. It is not an easy thing, and that's why it's so important for folks like Black Health Trust to both pull in those super scientist people like Dr. Hildreth and Dr. Hewlett, and the community folks that work across with people like Dr. Wyatt and others like Tony Wofford. We can't do what we do if we don't have folks like Tony Wofford involved, because we have got to get the information to the community in a way that the community can actually act on it. Like I said a while ago, public health is about getting people to do stuff and getting people to actually take action. So I appreciate you, brother. I appreciate you being here. I appreciate you coming back. And I would love to see if there are ways for us to collaborate with you and those that you collaborate with more. Dr. Neighbor-Stevens, I'll turn it back over to you.
Well, Dr. Sherrod has had her hand up for a while, so if we could unmute her, she can ask her question or make her comment.
Yeah, I want to thank Tony Warford for actually saying a lot of things that I have concerns about too. I think I agree with you 100% because we have such severe morbidity in the Black community that we as physicians cannot just do the mainstream pitch. We have to do things that are very specific to our population. Now, we know that there are three main factors that determines whether you get an infection. I'm getting back to treating COVID and influenza and all of that. We have all of this morbidity from diabetes and hypertension and all of that. So in our campaigns, and I really appreciate what Dr. Hewlett was saying about getting into the community, but I think our campaign cannot just be the mainstream, get your vaccine. You need to get your vaccine, but you also need to, one, test if you have symptoms, get early treatment, take your vitamin D. And I was just wondering if your campaign is including that. I mean, we have to use every tool that we have in our box when we go to the community. We can't just say, okay, get your vaccine, because we know that we got some really, really sick people who are still gonna get sick if they are not healthy, on healthy diets, and their immune status is poor, because the immune status is a major factor in whether, one, you even get the infection. And we know that vitamin D, and even on this Black Health Trust, I have felt uncomfortable even talking about vitamin D. There's a lot of data out there that has shown that vitamin D actually may determine whether you live or die once you get COVID. So those things we need to, are you pushing those things too in your global campaign when you go to the community? That's my underlying question.
Yes, we're looking at all of those things, although we didn't have a chance to elaborate on the treatments. Certainly in our health department, we are prepared to offer treatment for people that have, let's say, diagnosed themselves at home. And if they don't have a primary doctor, we're offering that, you know, the nirmatrelvir or Paxlovid as, you know, the trade name. So we're prepared to offer that. In terms of the people that we're talking to for our health literacy campaign, we're trying to take a holistic approach. I agree with you. When you look at vitamin D, there's so much data out there that shows that we as African Americans and Black people are more likely to be vitamin D deficient, and the key role that that plays in our immune responses. Especially, there's been a lot of work done in tuberculosis, where vitamin D deficiency seems to be a major factor there. So we're trying to look at all of it, but it's an uphill battle for us, obviously. And I certainly appreciate what Mr. Walford has stated, and we certainly are not in disagreement at all, not apologizing about interacting and collaborating with industry. But the only reason why I was cautious about it is that we can collaborate, but we have to make sure that we don't have conflicts of interest, because one of the problems I think that we face is that if we are too much aligned with the industry, we can lose our credibility in the community if everything that we're offering is with one company versus another. So I think we have to collaborate with all of them and not with just one particular company.
Dr. Hewlett, I want to be a woman of my word and uphold what I promised you, which is we would not hold you past 4, and we are very close to 4. I want to thank you again for helping us out today. Your presentation and your comments have been right on target, and we look forward to you visiting with us again in the near future.
Okay, I'll be happy to do so, and maybe you can allow me to bring in some of our junior colleagues, because you know, although we all hope that we're around for a long time, we know that there's going to be a need for us to pass the baton to others who are coming behind us, and for those people that are sort of standing on our shoulders to be able to interact in this kind of a forum as well. So thank you very much for having me.
You
Thank
know,
you,
and
Dr. Hewlett.
on that note, I'm in total agreement with what we have been discussing around involving the community and the role of Black providers and practitioners. But I want to, again, I think I have kind of brought this up before, but I want to remind this audience that please don't take for granted that we have Black physicians. The numbers of young people going into medicine are very low, and they face huge obstacles in completing the journey to becoming physicians. And the problems begin really in preschool. As a pediatrician, I will tell you that you can watch the light, that bright light in those eyes, be turned off by the time they're in the 2nd and 3rd grade. Many of our children do not have the background in their home that will give them the discipline and the skills for success. And I'm talking about elementary school, I'm not talking about high schoolers. And if you extrapolate that pipeline from elementary school to high school, where we have a terrific dropout rate among our children, all of which has been exacerbated by the interruption of the educational process during the pandemic, we are potentially facing an even worse situation in terms of the availability of Black physicians. And so I'm bringing this up because there are programs in many cities that are being conducted by various organizations. I am very active in a program here in the Tampa area, but I would ask all of our audience, if you have any young people in your life that potentially would want to become health professionals, encourage them and try to identify for them programs in your community. They're called pipeline programs usually, but programs in your community that they can become affiliated with, so that we can increase the drip in our pipeline to a flood.
Thank you.
Well said, Dr. Neighbor-Stevens. Well, Dr. Hewlett, thank you so much for being with us. And
Thank you for having me.
We'll see you again soon.
Okay.
Dr. Neighbor-Stevens, we do have a couple of additional comments. So if we can continue for a little while, that would be fabulous.
I believe
see-
Dr. Gibson has his hand up.
Dr. Gibson put his hand down. Dr. Gibson, did you have a comment? And then I think Tony Wofford had another comment he wanted to make.
Yes, thank you. I believe when the good doctor was doing his presentation, he mentioned that once there is a definitive diagnosis of the flu, that an antiviral should be brought on board. I actually wanted to try to catch him before he left to see if, because number 12 or Paxlovid is normally, should be anyway, taken within the first 5 days of the COVID infection. But when he mentioned the use of antiviral in a influenza infection, I didn't hear what product he recommended, or if he even did. I'm not sure, because I didn't hear that part and I missed it. And I was gonna try to ask him about that. Perhaps you may have heard what he said.
I did not hear
Okay.
the recommendation for a particular therapeutic. I know that what we always recommend here at Black Health Trust is that folks see their physician, because as we've talked about many times, your particular health, when I say your, I mean the general, your particular health situation is best left to your individual nurse practitioner, physician, PA, whoever it is that takes care of you. So we don't give specific medical advice. If you've got this, you take that. But we do talk a lot about there are treatments, and these are those treatments. So check with your doctor about the one that's best for you. It's sometimes challenging to not be able to do that. I have a good friend yesterday whose teenager tested positive for COVID and was actually sick, which teenagers, they're not supposed to get sick, but was sick and in bed and the whole bed. And I said, well, have you talked to the pediatrician about Paxlovid? Well, no, I don't want to give him any drugs. I said, really?
Yeah.
Your son is sick in bed and you don't want to give him any drugs. You won't even tell the pediatrician that he's sick. So we have a lot of challenges within our community with folks that have doctors. And so we really want to encourage folks to have a primary practitioner that they deal with. And Dr. Gibson, with your pharmacy background, you know that sometimes the pharmacist can save you when you come in with something that doesn't make any sense. So
well, I was just about to say thank you for your help on that one, and perhaps maybe the fact that viral challenges should be met as soon as possible, sooner rather than later. There has been mentioned, in fact, I think even today, that preferably within the first 5 days of diagnosis or the presence of symptoms, the patient should probably be treated, preferably with a primary care physician. But I believe the good doctor mentioned that they have programs. I'm not sure where he is. I think it's out in that high rent district of Westchester. But in other places there are ways, and maybe we can make that a project of putting folks together with a PCP so that when they need one, they don't have such a challenge trying to identify one that's willing to take them on, especially if they don't necessarily have access to the global network. Thank you.
Thank you, Dr. Gibson. Dr. Neighbor-Stevens, can we go back to Tony Wofford with his hand up?
Absolutely.
Okay, please.
Yeah, thank you. Appreciate everything that's been said. And I think one of the things that's very, very important, his brother said before he got off that we didn't want to seem like we were playing favorites with a pharmaceutical company. Well, we're not playing favorites. If you're willing to help me, I'm not playing favorites with you. I'm working with those that are willing to help me. And as people, I think we've got to figure out how you guys can collaborate better with community. Because again, if I'm working with you and you get any negative feedback from whoever it is, either the community, elected officials or whatever, then my job is to stand up and say, you don't know what you're talking about, man. Sit down. And again, we need to get these young people. Yes, we do need. I'm 66 years old. We need to get young people, young Black people into medicine. And I think what we have to understand is that we have to work together, because we can come up with all this stuff in the world, just like A. Philip Randolph did when he in there talked to Roosevelt. He said, all that's good, but you got to make me do it. We have to make these people do it. Power concedes nothing without a demand. It never has, and it never will. And unless we collaborate together, because again, I think when you get community on your side and community raising their voices and raising hell, because I ain't trying to write no white paper. I ain't trying to get published. My house knows the reason why I live where I want to live, so I can say what I want to say. I'm not going to say nothing crazy that'll make you look bad, but I'm sure going to say what you cannot say in the meeting. It's just, I got an HIV because nobody was speaking for my daughter. I got 3 girls, man, and no brothers was speaking up. So I had to put aside what I thought about men who have sex with other men. That wasn't none of my business, because what me and my wife doing ain't none of your business. But when Black people weren't getting the same treatment, when they would have dog walking service in West Hollywood and a brother in South Central couldn't get a Happy Meal, that was a problem for me. And I think what we have to do is figure out how we pull people off the bench that can make a difference and raise a voice. And if we go in a meeting and I'm raising hell, they'd rather deal with you than me. And they said, well, I'll calm him down. But we can still get the results together. We work together. Good cop, bad cop. People do it all the time. We just have to figure out how to, and not suffer stroke or amnesia, and how we deal with our own people.
No, don't be through. I think it's important for us to recognize that I grew up and trained in California. Mm-hmm. I'm on the East Coast in DC. Mm-hmm. Dr. Neighbor-Stevens is in Tampa. Dr. Maxey is in Los Angeles.
Right.
We all are doing things in different areas. A few
Right.
years ago, myself and one of the prominent pastors in DC and a couple of other pastors and doctors started an organization that went from being just a couple of folks having conversations to an organization that has collected millions of dollars in grants and has made a huge difference within the community in the DC area in terms of health status and health information. And we've had folks on Black Health Trust that have worked with doctors and communities. I'm not gonna say any of the names of the folks because I'm gonna forget the names, but I know we've had folks in San Diego, California, in Buffalo, New York, who have great programs that have made a difference in communities of color. And I think it's important for us to recognize that those are models. Now, what works in DC doesn't work in LA. I know because I've worked both places.
Absolutely.
But the ideas can spark the building of something that will work in LA that may be related in some way to what worked in DC or in Buffalo or in Atlanta. And so I applaud what you're doing, Tony Wofford. And I've never been accused of needing somebody to say rough stuff for me. I've usually been able to handle that myself, but I'm happy to have somebody say rough stuff with me. So if we need to talk plain talk to people, I'm happy to show up and I'm happy to do that because it's important to communicate. And sometimes the communication has to be firm and it has to be clear. It doesn't always have to be nice.
Right. And let me just finish with this. I lost 5 family members of COVID in May, brother, in 14 days. And I'm not talking about distant. I'm talking about 2 brothers, a niece, and 2 nephews. So I understand it's serious. This ain't no joke for me. This is real for me. Black health is serious for me. And again, I hope nobody misunderstood. I'm not saying that we ain't doing nothing black, because I don't talk black pathology. I talk black possibility, brother. So it's not like I don't understand and celebrate those of us that are doing good work all over this country. I did a health fair in Clarksdale, Mississippi, in a juke joint. So I understand you got to meet people where they are, brother, and build on what they have. So I got that. All the thing I'm saying is that it breaks my heart when I get calls all the time from people, Tony, I want you to help me with this. And the brother or the sister that called me is not the PI. That's a problem for me. And I know a lot of them can't. And I'm not as politically correct as other people. And I know a lot of them can't, and they do things differently. I just want to help, man. I ain't looking for a check. My house knows reasonable. If I could help in any kind of way, call me, brother. Because again, I live in LA, but I'm from Detroit. Don't get it twisted.
Well, I think that you being involved is absolutely a help. One of the things I do want to say that I think is important, all of the Black Health Trust programs are archived, or you can find them on YouTube. And we have had a lot of it has been prodded by Dr. Sherrod and others, but we've had people who have come on and have talked about the importance of prevention and fitness and vitamin D and my favorite, zinc. There are other things besides the vaccines that we have talked extensively. We had somebody on here one Sunday, Dr. Neighbor Stevens and Dr. Sherrod, who had us exercising in our chairs and showing us how to move around. So the overall state of Black health is a challenge for many of us. And as our friend who's also been on Black Health Trust, Jesse Jackson, Reverend Jesse Jackson, has said, we are the sickest and we're dying the quickest. And unless we stop being the sickest, we are not going to stop dying the quickest. It's just part of what we have. The one other thing, and I'll leave my little speech at this. I know it's important for us to work with people who look like us. There's no question about that, because there's a certain sensitivity there. And at the same time, everybody who look like us ain't for us. And so we have to be willing and anxious to work with whoever wants to work with us. And nobody has said that we aren't. I'm just making that statement because I don't want it to sound like if there's something exclusive about caring for Black folks and about the health of Black folks and about broader communities of color. You can look like anything you want to look like. If you care about what I care about, I want to work with you. And I think all of us on this screen feel the same way. Dr.
Dr.
Lawson has his hand up, Dr. Neighbor Stevens.
Yes, Dr. Lawson and then Dr. Sherrod. And then we will be probably at the end of the hour.
I just want to note the point that I've made before, that many of what's being said is wonderful. We need to get it out to the community, but I'm a regular listener to morning radio, listen to Karen Hunter, listen to the Black Eagle and so forth. These issues are not discussed. These issues are not discussed. The only thing that's usually discussed is the importance of getting sure that we get marijuana available and CMD all available. So so what the community, the millions of us are listening to, is nothing to do with these issues.
So let me just make a comment. Dr. Lawson just happens to be one of those folks that is a nationally recognized psychiatrist and a principal investigator on several projects. And we're always happy when you're with us, Dr. Lawson. Thank you for that. And we just have to keep speaking our truth. At some point, I think we have to start showing the evidence, like you did with the things that you worked on. So thank you for that. Dr. Sherrod.
Yes, I just wanted to clarify. I think Dr. Gibson pretty much answered his own question about the early treatment. And early treatment is good in any situation, but you're right, within the first 5 days, even with flu, because I'm not sure exactly what drug they're using for flu now, what antiviral, but when we were using amantadine, you had to give it 5 days before or not give it at all. So early treatment, you're right, is very important. And I think that's something that we need to emphasize in general in our population, because we tend to wait and wait until we just can't wait anymore before we go in to get treatment. So when you get the first symptoms of anything right now, you assume it's COVID until proven otherwise, because you want to treat it right away. And if you treat early, and there are some other things, and I know I can't get into them on here, but there are some other medications that have been documented to work in COVID other than Paxlovid, like clarithromycin and Valtrex. And I know that, it's not being talked about, but people, when you tell me that you've lost 2 brothers and a nephew and all, I'm sitting here wondering whether treatment would have saved them, early treatment. Even people who are vaccinated can get sick with COVID. And sometimes just knowing or having the drug name in your head and mention it to the physician, if they haven't heard about it, will help. So I just think we have to be forceful and do extra unique things for our unique Black community. Thank you so much.
Thank you, Dr. Sherrod. One of the things that I say to my patients every chance I get is that I will defend to the death your right to be an individual. And I think so many times we look at statistics, which are great for groups, but aren't really useful for the individual. And so you're right, having that name, you can say to your doctor, asking your doctor about how much vitamin C, because you can't take too much, but and vitamin D too, and zinc and all of that. But understanding that there are things to do in addition to Dr. Neighbor Stevens' common sense. You're watching. Look, after COVID, 5 years from now, 10 years from now, I still don't want you coughing in my face. I still don't want to grab whatever your hands have been holding. I still think that there's some things that we can do to protect ourselves and help each other that we need to continue to emphasize so that we can be as healthy as possible. We know diabetes, we know hypertension, those and others are really difficult for our community. So we have to talk about it. And I just really appreciate what we have at Black Health Trust, which is a forum for folks that we've had a lot of folks talk on Black Health Trust that don't have MDs, that don't have PhDs, but have a caring for communities of color, underserved communities. And I just think it's important that these kinds of forums exist so that we can have this opportunity to talk with each other. Dr. Neighbor Stevens, I've talked a lot today. I'm gonna just hand it over to you.
Oh, you haven't talked a lot. You know, we have a lot that we can bounce back and forth, and the hour is almost up and we're not going to be able to get into it. But I would like to, if my closing remark, and then I'll let you give the last closing remark. Stay tuned. There are new things, new developments every day. And we will try to stay on top of it and make sure that the appropriate light is shed on different topics. But if we miss something, please feel free to bring it up and we will, or you can contact Black Health Trust and we will certainly try to address it. Now, what is prompting that comment is we have had several talks by some very knowledgeable people about what viruses do. So we all should know, regular listeners should know, the main activity of viruses is to replicate, and in the process of that, they mutate. And so the mutations are beginning to pop up. Keep an eye on it. Keep an eye on what is prevalent in your local community. We know that the different strains appear at different rates in different parts of the country. So pay attention to what's going on in your local community. And we look forward to being with you again next week. Dr. Walks.
Thank you, Dr. Neighbor-Stevens. Every time we talk about flu, it reminds me of Michelle McGlory and Robert French. Who are they? Those are two of my high school classmates that died from the flu. I went to high school a long time ago. Flu's been killing people for a long time. And I think it's important for us to recognize that a lot of people die every year from the flu. I got my flu shot earlier this week. And unlike the COVID vaccine, which I took it and I was fine, flu shot made me sick for a few days. And somebody said to me, see, that's why I don't take the flu shot. And my response was, you must have never had the real flu, because what I went through for a couple of days is nothing like the real flu. So I just encourage people to talk to your doctor, get good advice, protect your health as much as you can, and say what I say to people who say to me, you know, I'm going to start getting in shape. Soon as I have some time, I'm going to start eating right. I just look at them very seriously and I say, no, you're not. Do what's good for your health now. We started by, I think Dr. Neighbor-Stevens talking about the children of Israel and having to wander in the desert for 40 years. So I'm just going to end by saying that God bless all of us. Thank you so much for being with us today. And we will see you next week.
Bye.